Hello friends, welcome to today's class. I'm just trying to get started with this, so just give me a minute. Hi Ayushi, hello Abhirami. If I'm loud and clear, please let me know. It's just getting loaded. Just give me a minute, it is still loading on my phone. Once it's started, then I will be able to see your comments also. Great. So if you can see me well, if you can see me clearly, just wave out to me, give me a thumbs up so I know you are with me, and then I will begin today's class. On my phone, I can see your comments, so whatever doubts you have, you can ask and I will reply to them at that time. Alright, Ijia, Ayushi, Meena Devi, Arup Biswas, Dr. Dilpreet are all online. So just give me a thumbs up, just tell me if I'm loud and clear, and then I will begin. Hello Harshita. Alright, so I think I'm loud and clear. So before I begin, let me introduce myself. I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai and I teach general surgery for MCQs, which you will require for AIIMS, for PGI, for NEET PG, and all those competitive exams. This is my referral code dramrit-yt if you wish to see me on the Plus platform. And currently I am teaching the capsule course on trauma and recent advances, which you can see on my profile. That's me right there. So let us begin on AIIMS pattern MCQs for today. So you know there are some topics that they love asking. So some are basic general surgery, knotting, suturing. So this is one from that topic. So identify the type of needle. Is it a cutting needle, reverse cutting needle, taper cut, or taper point? Please try to let this be a two-way conversation so that I know you are listening to me and we can solve your doubts as and when they appear. So is it a cutting needle, reverse cutting, taper cut, or taper point? Yes, go ahead. Okay, I have gotten all the options. Abhirami and Ijia say reverse cutting. Raghu is saying taper cut. Ken is saying A. Ayushi is saying B. Meena is saying D. Surya is saying D. So I tell this in all my classes. The thing about AIIMS is there are only 200 questions. So every question that they pose, they put options very close to each other. And as you are seeing, all of you are choosing all four options. That makes this question a highly discriminating question. So this question has a good discriminating value. So it is a very high discriminating question because a lot of you are choosing different options. So the examiner is happy with this. Okay, so some of you are right, a lot of you are wrong. How do you identify the needle? It's very simple. Look at the cross section. They have given you the cross section for a reason. Now, if you look at the cross section, it is triangular and the sharp edge or the cutting edge is outside. If it is triangular in cross section with the sharp edge outside, then it is a reverse cutting needle. If the sharp edge was inside, that means if the cross section was like this, triangular, but the cutting edge is inside the angle of the needle, then it would have been a cutting needle. Let me show you a better pictorial representation. So look at these two. These are your cutting needles. Alright. The other types of needles that you see over here are called tapering needles, or they are also called round body needles. Commonly when we perform surgery, we don't say tapering, we say round body needles. So the difference is over here. Always see the needle in cross section first. That is the tip for you for today. Look at the needle in cross section. If it is a triangle, it is cutting. If it is circular, then it is tapering, or round body. Circle is round, so it will be round body. So that is how you differentiate tapering from cutting. Now, in cutting, if the cutting edge is inside, on the inside edge, the inner part of the needle, then it is the normal cutting or curve cutting. If the cutting edge is outside, then it is reverse cutting. About round bodies, there can be tapering point or blunt tapering round bodies, but they are basically the same. Remember that round body needles are used for bowel or vascular anastomosis or vascular suturing. Cutting and reverse cutting needles are used on tough structures like skin and fascia. That is the fundamental that you need to understand about needles. Alright, I hope I am clear. Right? I hope I am clear with that. Now, where do you use straight needles? These are all curved needles which you see commonly. Any indication for using a straight needle? Has anyone seen a straight needle being used? Has anyone seen a straight needle being used? So straight needles, just for your reference, are used in suturing of bone. So if you have done a sternotomy and you want to suture back the sternum, you can use a straight needle. Similarly, straight needles are used in laparoscopic surgery. Okay, in laparoscopic surgery, sometimes it is easier to use a straight needle. I will not tell you where in laparoscopic surgery, there are different examples, but for convenience, just remember straight needles can be used in laparoscopic surgery also. Alright, so Maya, sheath, no, sheath is cutting needles. Now look at this image and identify the syndrome. This has never been asked before. Okay, but it's a very easy question. These are the kind of questions they ask in AIIMS. They are not really testing your theory, they are just testing your application, your fundamentals. And so identify the syndrome associated with this pathology. Is it xeroderma pigmentosum, meant to be syndrome, Peutz-Jeghers, or Gardner's syndrome? Okay, a lot of you are jumping at the answer. Samir, Raghu, Ramesh, Ijia, Maya, Dilpreet, Pooja Kumari, Arup, Ken, yes, absolutely right. You all are absolutely right. Look, remember this question. This has not been asked yet. This is Peutz-Jeghers syndrome. This is lip pigmentation seen in Peutz-Jeghers syndrome. Now, what is Peutz-Jeghers syndrome? I'll tell you later. Just a few points about these other disorders. Remember xeroderma pigmentosum. Xeroderma pigmentosum is a precancerous lesion for skin cancers. Meant to be, it has medullary thyroid cancer, pheochromocytoma, and cysts like epidermoid or mucosal cysts. That is meant to be. Gardner's syndrome is one of the familial adenomatous polyposis coli syndromes. Alright, so that is Gardner. The other syndrome that you get in FAP is Turcot. Okay, the other syndrome that you get is Turcot. Now, colonic polyposis, extremely important topic. It's quite, it's not that difficult once you have a structure. So basically there are two types of colonic polyps. The non-neoplastic ones that are the hyperplastic. This is the most common type. The juvenile types and the hamartomatous types. In Peutz-Jeghers you get the hamartomas. They are predominantly seen in the jejunum. Apart from that, you see lip pigmentation that you saw in the image before. Neoplastic polyps are the adenomas. They can be villus adenomas, tubular or tubulovillus. Right? They are villus and they are all neoplastic or pre-malignant. The syndromes associated with them are the FAP, familial adenomatous polyposis syndrome, and the HNPCC, that is hereditary non-polyposis colonic syndrome, colonic cancers. All right, so colonic polyposis, extremely important topic, must know for all your competitive exams. Now let's come to something else. This image has been asked before. So identify this pathology. Yes, Maya, mucocutaneous pigmentation. That's right. Identify this pathology. Don't jump to the answer. Okay. Is it gastroschisis, omphalocele, ectopia, or intestinal atresia? Identify this pathology. These are the kind of image-based questions they commonly ask. This has been asked before. Okay. Maya is saying omphalocele. Dilpreet is saying ectopia vesicae. Okay, interesting. Anyone with a different answer? Okay, a lot of people going for omphalocele. This is not intestinal atresia. Do the intestines look normal? Don't follow what others are saying, guys. Please follow what you feel is right. Okay, Pooja, Raghu, Abhirami, Ramesh, Arun. One last chance. Omphalocele, Meena Devi. Okay. Yes, you guys are right. This is omphalocele. This is omphalocele or exomphalus. Okay, this is omphalocele. Why is it not gastroschisis? Why is it not gastroschisis? Anybody? Why is this omphalocele and not gastroschisis? Yes? Present in midline. No, I don't see the midline to say that it is present in midline, Arup. That's wrong. Present in midline cannot be differentiating. Covered. Absolutely right. So this membrane, this covering is nothing but peritoneum, not mesentery. This is peritoneum or the sac. So as you know, any seal, any ocele like a hydrocele or a hernia, which is an enterocele or an omentocele, has to be lined by a sac of peritoneum. If you see the peritoneal sac, it is omphalocele. Omphalocele is nothing but a defect in the abdominal wall. It is commonly associated with midgut malrotation. Commonly associated with midgut malrotation. The gut doesn't rotate, the gut doesn't come back, it remains outside. If it is covered by peritoneum, it is omphalocele. This what you see over here. This is gastroschisis. Alright, this is gastroschisis where you see the bowel is bare. So this is also in midline. It can be anywhere where the abdominal wall is absent, but here there is no peritoneum covering it. The bowel is bare and exposed, but it is normal, right? So it is intestinal erosion present in gastro. Okay, so this is gastroschisis. Yeah, and this what you see over here, this is the important part. Look at this. Forget this that you see. This is the important part that you see over here. There is a lower abdominal wound. It's just a wound. You don't see any bowel. It's a lower abdominal wound in a child. This is ectopia vesicae, also called as bladder exostrophy. Yes, Arup, this is ectopia vesicae, where the lower abdominal wall is weak or absent and the bladder trigone is exposed. Obviously, you can't make out that it is bladder trigone because granulation tissue forms on top of it. So this is ectopia vesicae. Alright, what you see over here, they are groin hernias which have eroded the skin, which are associated with ectopia vesicae. And there is a fourth option that I gave, that was intestinal atresia. Now, in intestinal atresia, there is no defect. So there is no abdominal defect. If you see an intestinal atresia image, obviously in an intestinal atresia it will be a surgical image, which means there will be a laparotomy. You will not see a child wearing his clothes or a nude child. You will see surgical drapes. It is a surgical procedure where the abdomen is opened and the atretic intestines are exposed. Alright, so remember that trick to identify a surgical image where the child will be draped, only the abdomen will be exposed and opened, and if you see the intestines, that will be intestinal atresia. Not a child wearing normal clothes or an exposed child. Alright, that cannot be intestinal atresia because that is inside the abdomen. Now, this is one of the famous and hot topics for NEET and for AIIMS. They love asking this, so I have tried to complicate it a bit. Please think before you answer this. So they love asking this GCS, and I have put a test in my a quiz in my course that is there on the Plus platform, where I have put a lot of GCS based questions for practice. Following a road traffic accident, a male patient is brought to casualty. GCS assessment is performed. Patient is abusing the nurses, opening his eyes in response to sternal compression. Left upper limb is localizing pain. Right side he is withdrawing to pain. What is his GCS score? What is his GCS score? Every exam in AIIMS they are asking a GCS. Alright. Don't follow what others are saying. Please think carefully and think tactfully. There are two aspects here. One is response to sternal compression. One is localizing pain on one side, withdrawing to pain on the other. Alright, what is his GCS? E2, M3, V5 or A. Okay, alright. Now let us analyze each point by merit. Okay, let us analyze each point by merit. So you remember it's best eye opening, best verbal, best motor. Now, best eye opening, patient is opening eyes in response to sternal compression, that means in response to pain. So that is E2. So B definitely is out. B cannot be the correct answer. I am happy I've gotten all the options from you, A, B, C, D. Now, verbal response. He is abusing the nurses, which means he is speaking inappropriate words. That becomes V3. Now, this is M. Left upper limb localizes pain. That should be 5. Right side withdrawing to pain. That should be 4. So, is it 4 or is it 5? Remember, the trick is EVM is best. Best eye opening, best verbal, best motor. So the best motor response is 5. Alright. The best motor response is 5. Remember this, if they give you a complicated image like this where right side something is happening, left side something is happening. Earlier he was opening his eyes, now his eyes are opening a little less. Remember, it is best. So M becomes 5. Answer is E2 V3 M5. Yes, Ijia, absolutely right. It is the best response. So GCS is disability assessment, part of ABCD in trauma. Right. So remember, I have written best for everything, which is what you need to look at. So this is 4, 3, 2, 1. This is 5, 4, 3, 2, 1, and this is 6, 5, 4, 3, 2, 1. A pointer here. If the patient had trauma to his eyes, so when he came, his eyes were covered in dressing, then how would you assess the eye response? Anybody can tell me what is the eye opening or the eye response in GCS if the eyes are covered with dressing and the patient is not allowing you to remove the dressing for you to look at the eye opening, or if the eyes are absolutely swollen, the eyelids are swollen and he is not able to open the eyes because the eyelids are swollen. Yes, Ramesh, absolutely right. If you cannot assess any test, it is called as NT. So E will be ENT or non-testable. So Ramesh, Ijya, Maya, Priyanka, you are all absolutely right. Remember, same goes for verbal. If he is tracheostomized or intubated, V will be VNT or non-testable. If he is paralyzed with muscle relaxants, then M becomes NT. Alright, remember this. They can put this also. So this is the GCS. If you look at all the past recent AIIMS exams, there will always be a question on GCS. Alright, this is my own question. This has not been asked before. Identify this pathology. This is in the mouth. Okay, this is the tongue. This is the uvula and this is the pathology. Just for your help. What is this pathology? Is it an annula, cystic hygroma, ectopic thyroid, or a papilloma? Please think carefully. A simple pathological image, the kind of questions they ask in AIIMS. Maya is saying ranula, Khamas, Abhirami, Samir, Dilpreet is saying C, Pooja is saying D, Maya is saying A. Okay, everybody's bit between A, C, and D. Anybody for cystic hygroma? I have gotten all of these options except cystic hygroma. Nobody is going for cystic hygroma. This can't be that. Most of the people are saying ranula or ectopic thyroid. Okay. Nobody for cystic hygroma. This is not cystic hygroma. Okay, interesting. Ramesh is saying cystic neck. Maya is saying no, not cystic. Yes, absolutely right. It's not a cystic hygroma. That you are correctly eliminating. Circumvallate papilloma, that Meena is saying, well, Meena, there is nothing like a circumvallate papilloma. That is my own creation. At least I have not read about it. So there is no such disease. So the doubt is between these two. Ranula is seen in the floor of the mouth. Ranula is seen in the floor of the mouth. That is underneath the tongue. Alright. So this is by elimination an ectopic thyroid. Or better answer is lingual thyroid. That someone said earlier. So this is a lingual thyroid or an ectopic thyroid. Remember that the most common site of ectopic thyroid is this lingual or foramen cecum. The most common site of a thyroglossal cyst. Thyroglossal cyst is not the same. The most common site of thyroglossal cyst is subhyoid. Remember, thyroglossal cyst is subhyoid. Now, look at this. This is a ranula. Ranula, it is an extravasation cyst in the floor of the mouth. It occurs due to blockage of glands of Nun and Blandin. Nun and Blandin, they are the sublingual salivary glands. Sublingual salivary glands of Nun and Blandin, when they get blocked, the glands become bigger, then the glands rupture, which is why it's an extravasation cyst, because the glands have ruptured and gotten covered by a membrane. That is a ranula. As you know, when the ranula extends downwards into the neck and if it pierces the mylohyoid muscle, if it pierces the mylohyoid muscle and enters the neck, It is called as a plunging ranula, where it plunges into the neck. Cystic hygroma, someone said correctly, it is a neonatal pathology. It is a neonatal pathology. It is a sequestration cyst where the lymphatics get sequestered. So the lymphatics and the lymph node sacs, they form during embryology, and the lymphatics join the lymphatic sacs. If the lymphatics fail to join the sac and they get separated from the lymphatic tree, they form a sequestration cyst, that is your cystic hygroma. The most common site is the posterior triangle of the neck, and the most common presentation is obstructed labor. The most common presentation is obstructed labor. Yes, seen in Turner's syndrome. Absolutely right, Kaushal. It is seen in Turner's syndrome. That's right. So that is a cystic hygroma. This image is a ranula, and the earlier image was a lingual thyroid. Okay, this is an easy question. Basic question. AIIMS will always have these basic biochemical questions that you must know. These are the questions, if you can't answer or if you get them wrong, then you will not get a rank. They are also asked in NEET PG. This is my own question, but I'm sure you will find things like these in the books. Which of these is not a marker of chronic liver disease? Because they test you on all grounds. They will ask you complicated clinical questions and they will ask you simple clinical questions. Okay. Maya and Priyanka are saying AG ratio. A1 is saying bilirubin, and Sheikh Samir is saying GGT. Okay. And Ken has asked, sir, for ranula's treatment, marsupialization or incision and drainage. For ranula, the treatment is excision plus removal of the affected salivary gland. That is the treatment. Excision along with removal of the salivary gland. If excision is not possible, then marsupialization. If you cannot excise, then marsupialization. This is the sequence. But let's come to the task at hand. My god, you guys, A, B, C, D, all options I am getting for not a marker. This I thought was the easiest question, but this has become the best question. It has discriminated the class unbelievably. I am surprised. This has the best discrimination of all the questions. I thought I have not even left an explanation for this, thinking everybody will get this right. So all of you, I cannot individually point out, but all of you are given all of the options A, B, C, D, my dear friends. Not a marker of chronic liver disease. By common sense, what is a marker of acute liver disease? If someone has an acute liver disease, like say a hepatitis, which is the marker of hepatitis? The answer is liver enzymes, SGOT, SGPT. Which is the only enzyme that you see over here? Answer is GGT. The answer is GGT. AG ratio, PTINR, bilirubin are all synthetic or excretory functions. They are all markers of chronic liver disease. Friends, if you didn't know this, all you had to think of was the child score. All you had to think of was the child score. These are all components of the child score. Is the child score for acute liver disease? No. It's a marker of chronic liver disease severity. Then how the hell can they be markers of acute liver disease? Aren't these the parameters in child score? I'm surprised nobody got this right. Child score is chronic liver disease. I asked you not a marker of chronic liver disease. These three should have been eliminated and the answer is GGT. Alright, I'm surprised so many of you got this wrong. Please think simple things first. Don't jump to the answer. Alright, please do not jump to the answer, you will make a mess. Alright, this is the last question for today. It's a clinical question, clinical imaging question. 50-year-old female recently diagnosed diabetic, presents with this rash, suffering from depression, What blood investigation do you advise? Okay, what blood investigation do you advise? If you cannot identify the image, it's okay. The image is just giving you some extra information. Even if this image was not there, you should still be able to answer. Okay. Preet, VZ, they are saying D, glucagon. Okay. Okay, the hint is in the options. You are thinking about endocrine tumors of pancreas. That's the hint. Endocrine tumors of pancreas. Anybody can tell me what this lesion is? You are all saying D for fasting glucagon. What is this lesion? All of you, Ijia, Raghuvarma, Surya, Ramesh. Yes, absolutely right. Absolutely right. This is necrolytic migratory erythema. Necrolytic migratory erythema. Remember that is glucagonoma. So you will measure fasting glucagon levels in this patient. No, Ayushi, it is not chromogranin, and I'll tell you why. Endocrine tumors of pancreas, extremely important topic. Extremely, there were two questions from endocrine tumors of pancreas in NEET PG this year. Alright, cannot make a mistake in this. So, for convenience, these are the five neuroendocrine tumor groups of pancreas where insulinoma is the most common. Presents with Whipple's triad. I hope you know Whipple's triad. Gastronoma, which presents as Zollinger-Ellison syndrome in the triangle of Pizarro, is the most common type in men syndrome. In men 1, gastronoma is the most common type. Then you have VIPoma, which presents with Werner-Morrison syndrome, that is watery diarrhea, hypokalemia, achlorhydria. Glucagonoma, that was the question asked. Remember the 4Ds: diabetes, dermatitis, this was the rash, NME, DVT, and depression. They may give you an option of diarrhea to confuse you. Remember, diarrhea is not seen in glucagonoma. Remember, it is seen in VIPoma, gastronoma, but it is not seen in glucagonoma. Alright, the 4Ds are diabetes, dermatitis, and DVT. Okay, remember DVT and depression. They are the 4Ds, not diarrhea. And then the non-functional ones where you get chromogranin A or synaptophysin positive. Alright friends, so I hope you liked my class. As you know, I am an educator on the Plus platform. These are my upcoming courses. Currently I am doing this course which will get over soon. After that I'll go to super specialty, then to general and to GI, where I will cover all of these topics comprehensively, so that in about 20 to 25 hours of my classes, everything in surgery for all of the exams will be covered comprehensively. On the Plus platform, it's not just me, there are a lot of great teachers. I hope you are following them. Dr. Rajamahendran is there in surgery, Preeti Sharma, Nikita Nanwai, and the likes. So you will have access to all of us. And if you wish to subscribe and you wish to use my code, you can use this code as I told at the start of the class, Dr. Amrit YouTube or YT. That's my code. You can pick any of these courses and you will have access to all of us on the Plus platform. You can also attend my other YouTube and free classes to get some more idea. I hope this class was useful. My last message for you is just be vigilant when you see the question. Do not jump to give the answer. Alright, AIIMS is full of tricks because there are very few questions and they want to discriminate, so be very careful and look at all the options. Alright, there will be a very small difference in the options and you have to get the correct answer. Thank you for joining me. You have been a great interactive audience and I will see you soon. Have a good day.